Hello, everyone. Dr. Anthony Gonzalez here again with you at Miami Community Newspapers. We're here to talk to you again today about health and Miami community health. I'm Dr. Anthony Gonzalez, and I have with us today Pascual De Santis. He's our endocrinologist from Baptist Health Medical Group, and he's going to talk to you about all those little details of endocrinologists deal with, specifically diabetes. We're here to talk to you about diabetes, of course, because November is Diabetes Awareness Month, and I'm sure somebody in your family or somebody in your neighborhood or in your community has diabetes and deals with diabetes. So definitely it's going to be an important topic to talk about. So welcome, Pascual De Santis, for being with us.
Thank you for having me. Thank you.
Alrighty. So what I always like to do is start off by, telling us a little bit about yourself. The viewers always like to know who's speaking to them. So tell us a little bit about you.
So my name is Pascual De Santis, as you said. I am from Venezuela originally, and came to the States in the mid-90s for residency after graduation, and did all my training here in the United States. And so I did internal medicine at the University of Miami Jackson Memorial Hospital, and then went on to do some clinical pharmacology at Georgetown University, and then finally ended up in WashU, Washington University, to do the endocrine fellowship. And then came back to Florida after many years because of my wife, essentially. And so, and we've been living here in South Florida for 15 years now, something like that.
Great, great. So you're an endocrinologist, and you're an endocrinologist at Baptist Health, and Baptist Health obviously has primary physicians, and I work for Baptist as a surgeon. Tell us what an endocrinologist does. What type of patients do you take care of?
So we essentially work with the hormonal systems, okay, in general, and that implies several systems. I would say 50% of our patients are diabetics, and that is a disease that has to do with a hormone called insulin, okay, and that's part of the endocrinology. But we also do other related issues with the thyroid, pituitary gland, adrenal gland, parathyroid glands, and metabolism in general.
Alrighty. So mainly, obviously, you're seeing patients who are diabetic, and then people who have other hormonal issues with some of these other glands. Okay.
Right.
Well, our focus today is going to be on diabetes. And, as I said in my opening, diabetes affects almost every family member. I remember 20 years ago or so, when my nephew was diagnosed with diabetes. I was telling you that story, and how it impacted our family, totally, and how it can impact the family. So tell us a little bit about diabetes. What is diabetes?
So diabetes is a condition where the body is not able to handle glucose, precisely because there is an issue with insulin secretion. It's a bit more complex than that, of course. There are two main kinds of diabetes. There are more than that, but essentially two main kinds of diabetes. 90% of the diabetes you encounter is called type 2 diabetes. The other 10% is what we call type 1 diabetes. Your nephew, very likely, as a young child when he was diagnosed, is a type 1 diabetic. The main difference between the two of them, there is insulin secretion impairment in both of them, okay? But the type of impairment in type 1 diabetes is almost absolute and complete. In type 2 diabetes is much less of a problem initially. Initially, the dominant mechanism is what we call insulin resistance, which is an interplay of genetic factors and environmental factors that you also deal with, related to sedentarism, obesity, bad eating habits, and so on. And so at the beginning of type 2 diabetes, that's the dominant mechanism, because the insulin capacity of the pancreas remains somehow still. As type 2 diabetes progresses in the natural history of type 2 diabetes, there is a decline in the insulin secretion. After many, many years of diabetes, many type 2 diabetics do become insulin dependent. That doesn't mean that they become type 1 diabetics, but they do become insulin independent as a result of the significant impairment of the insulin secretion.
So it's obviously not enough insulin, and of course it could be some insulin resistance where your insulin is not able to do the work it needs to do. But, if you eat too much sugar, can you become diabetic?
So, as usual, there we're talking about the risk for type 2 diabetes. So eating too much sugar, I think that's a statement that involves some of the risk factors for type 2 diabetes. By itself, it's not enough to cause diabetes. You do have to have a genetic background that predisposes you to that. So it's an interplay between the genetic predisposition and the environmental factors in which eating habits, including sugar, but not only sugar, but saturated fats and processed foods and etc. also increases the risk of becoming type 2 diabetic. But again, it has to be in the appropriate genetic background for that to happen.
All right. So then we have the type 1s, which are usually the ones that are that need insulin and who are younger. And then we have the type 2, which are the older ones, which are more acquired, where they get it older in life. And of course, obesity is one of the risk factors, right? And that leads me to my question of pre-diabetes. And this is really a question that I ask the patients. So, as a bariatric surgeon, I see patients who come to see me and they're morbidly obese. They are 100 pounds overweight. And they say, I have high blood pressure and pre-diabetes. And I said to them, what does that mean? What is pre-diabetes? So tell me, what is pre-diabetes?
So the first thing we have to know is this is a continuum, really. The thing is, the ADA has established some criteria to really differentiate one from the other. So pre-diabetes is, as the term implies, a pre-state to becoming a diabetic. From a formal perspective, there are well-defined criteria based on the fasting glucose, hemoglobin A1C, and the 2-hour after glucose challenge criteria to define whether the person is normal, pre-diabetic, or diabetic. In general terms, is this state in which you are your sugar metabolism is not normal, but you're not in a diabetic state yet. And it increases tremendously your risk, not only for diabetes, for cardiovascular disease and some complications as well. So we do see some neuropathy in pre-diabetics and so on. And whether the person goes on to become diabetic or not depends on what type of intervention you do and when you do that type of intervention. But in general, I think it's important to emphasize that this is a continuum, really. It's not like something that is demarcated by a switch that you go on and off and become one or not. It's a continuum.
So they're on the road to diabetes, basically.
Correct, basically.
They're on that road, and if they don't get off that road and make a turn, then something's going to happen. Okay. So how common is diabetes? How common is diabetes in our country and in our community?
It's unfortunately very common. And if you look at the CDC data from the 1950s up until now, you can see a significant increase in the incidence of diabetes, which parallels the incidence of obesity. And if the trends continue the same, by year 2050, 1 in 3 Americans are going to be diabetic, unfortunately.
Wow.
Most of them, of course, are type 2 diabetics, like we said at the beginning. But that's only the tip of the iceberg. Pre-diabetics, so it's about something like 30 million people diabetic, but something like 90 million people pre-diabetic at one point in time. And so it's something that it's a moving target in reality, and it's moving up over time. And like I said, it has paralleled the lifestyle changes in our culture, the very little time to cook, a lot of processed food, driving everywhere, not walking, not being active, video games, computer work, etc. So all of these, it's if you will, it's almost like a sociological issue, not just a medical issue, right?
Yeah, no doubt about it. So it's exactly that. Eating the wrong foods and gaining a lot of weight, and that what's happened to the super size of America. Mm-hmm. We're supersize everything. We want everything bigger. We want double of everything. So of course, that's led to diabetes. So we talked a little bit about obesity being a risk factor, and of course, I see that in my practice, the obese patients that have diabetes. What other factors do you look at? Does somebody look at that's looking at this show and says, "Hey, doc, could I be at risk for diabetes? What other risk factors could there be?"
Very important question, because that's exactly where you want to catch these people, right? At the risk factor level. And again, we're talking about type 2 diabetes, remember, because type 1 diabetes, the mechanism is autoimmune. And again, it's also a genetic predisposition and so on. But so talking about type 2 diabetes, the risk factors are essentially sedentarism, If you have a family member, a first degree relative with diabetes, you're going to have a higher risk for diabetes. If you have hypertension, that is a risk factor for diabetes. If you're a woman and you had gestational diabetes, then obviously you're going to be, that's Hispanic women with a history of gestational diabetes is the highest group, the high risk group.
Wow.
There. Well, ethnicity is a risk factor. Pretty much you can think any ethnicity other than Caucasian is a risk for diabetes. Any other, Asian, African American, Hispanic, Asian Americans, Native Americans, all of those are predisposed to diabetes. And so that's about it. I don't remember any other ones, but those are the main ones. Yeah.
Wow. So yeah, of course, there are some things you can't change there because you can't change your ethnicity, you can't change your family history, and if your family has had it, right. But you definitely can get off the couch and stop watching Netflix and video games. That's for sure. Okay.
Right.
So those are good factors. I mean, I think what we're telling people is to eat less and more activity.
Yeah.
That'll decrease your risk.
Right.
All right. So you are diagnosed with diabetes, and your primary doctor or your emergency room diagnoses you with diabetes, and they send the patient to you. How is diabetes treated?
Well, it all depends on how far are you in that diabetes. Because the truth is that when a person is diagnosed with diabetic, especially those people, young men who do not go to the doctors routinely, right? It's thought that once they are diagnosed with diabetes, they probably had it for 10 years before they were diagnosed with diabetes. Wow. And they didn't know about it because they didn't go to the doctor, right? So by the time somebody gets to the endocrinologist, really, they're probably very advanced, right? And so the way you treat it depends on how high this parameter called the hemoglobin A1C is and what is the random blood sugar, okay? You could start somebody on insulin right from the get-go, depending if they're symptomatic, they're having excessive thirst, excessive urination, their blood sugar is over 300 and the A1C is above 11. According to the ADA criteria, right there you have somebody who probably needs insulin right away. That doesn't mean that they're going to remain on insulin, but at the beginning, it's a good strategy for safety issues to start them on insulin. If the situation is less problematic and they have an A1C of 8 and the sugars are in the high 100s and 200s, you can start there is an algorithm, stepwise approach as to how you start diabetes treatment. The cornerstone, the first line therapy is always a drug called metformin, which you start first, and then obviously effective lifestyle modification. So we tend to undermine sometimes the efficacy of lifestyle modification, and frankly the reason why is because people don't do it. So as a doctor, you don't count on that as much because you assume that most people are not going to go that far. But the reality is when somebody does, every once in a while when you encounter somebody that does take this seriously and engages in significant lifestyle changes, you would say that at the beginning is the most powerful intervention that you can use. But anyway, talking about drugs, you start a stepwise approach in which the first step is metformin, and then on top of metformin, you build the regimen depending on the person's needs. Nowadays, it's very important also to consider, and this is relatively new within the last few years, cardiovascular risk, because the newer diabetes drugs have shown cardiovascular protection that seems to be beyond the glycemic control. So the GLP-1 analogs and SGLT2 inhibitors, two classes of medications that are new, that were originally designed to treat diabetes, have shown to have super good cardiovascular profile, reduction in cardiovascular mortality and events. So if somebody has either a cardiovascular event in the history or heart failure, you are to take one of those, or put the person in one of those drugs preferentially. So it's a bit complex, but you do have to take into consideration cardiovascular risk because it does make a difference in the choices of medications you use.
Oh, great. So obviously we're learning how to treat them. Now, there was a test you mentioned there, which, of course, I think our viewers need to understand. We check blood sugar. I can poke my finger and know what my blood sugar is right now. But you talked about the hemoglobin A1C. Tell us what that is. Explain to them.
Sure. So the hemoglobin A1C, everybody knows what hemoglobin is, right? I mean, it's the thing that you're tested for anemia. It's that protein that is within red cells. So it turns out that in a lifespan of a red cell, that hemoglobin within the red cell is exposed to the sugar that is in the bloodstream, the sugar concentration that is in the bloodstream. So there is always a percentage of that hemoglobin that is glycosylated, which means has a sugar attached to it. And the percentage of that glycosylation depends on the concentration of the blood sugar in the lifespan of the red cells, right? So a red cell lives around 120 days or so. So whenever you draw blood and you measure how much of that hemoglobin has a sugar attached to it, which is to say what percentage of that hemoglobin is glycosylated, you can extrapolate what has been the concentration of the blood sugar in that person's for the last 3 months up until that time. And that gives you a very good idea of how the concentration, on average, obviously. It doesn't give you the idea of the swings of the blood sugar, but it gives you an idea of the average concentration of the blood sugar for the last 3 months prior to that moment.
Yeah, and I think that's something very hard for me to explain to my patients, that I can get a blood test and know how high your blood sugar has been on average over the last couple of months, and that level has been associated with outcomes after surgery. So there are some surgeries that we don't do on patients when that number is very high, because the risks and the complications after surgery are much higher.
Absolutely.
So definitely that number is very, very important. So diabetes. So why is diabetes important? Is it going to kill me? Am I going to die of diabetes? Can I die because of diabetes? What are the consequences?
Right. So essentially, long-term uncontrolled diabetes has shown in population studies to cause significant morbidity and mortality, coming essentially from two different kinds of complications, either macrovascular complications or microvascular complications. The macrovascular complications are thought to be the cardiovascular ones, stroke and heart attack. The microvascular complications are the ones related to kidney function problems, retina problems or eyesight problems, and neuropathy, which are the nerve ending issues. And so all of those complications, yes, they can kill you at some. It's hard to say that way, but they do. Each one of them can. Different ways. Obviously, heart attack and stroke can kill you in that way. Kidney failure can do it. And in many times, they're actually coexisting together. Many of these complications exist at the same time in those people. The neuropathy can kill you in a way that leading to infections in the limbs and so on, that can cause gangrene and sepsis and can lead to death in that way. Retinopathy, essentially you go blind. I mean, it's a risk of going blind. That essentially doesn't kill you, but like I said before, usually it coexists with renal failure, retinopathy in particular.
Wow, so you definitely don't want to become diabetic, and our viewers are adults, and they're obviously at the risk of being sedentary or being Hispanic or being a woman or being obese. They could become diabetic, and obviously these consequences are detrimental to them. Now, if somebody is pre-diabetic, do you treat them? Do you see pre-diabetics, and what type of treatment do you give a pre-diabetic?
Right. So, and that's, I think, from a preventive standpoint, that's the most important group that we need to attack. And we can go on and on and on when to start. I think we should start it with the small kids. But anyway, in that population of pre-diabetic, the majority of them, they don't know they are pre-diabetic. And that's essentially that group of young people who don't go to the doctor. So the main thing is go to the doctor, especially if you belong to a high-risk group that we discussed before. You have a high-risk profile that we discussed before, right? So go to the doctor because you're going to be tested. Once you are in a pre-diabetic state, by the ADA criteria that we discussed, the most important evidence we have is called the DPP trial, Diabetes Prevention Program trial. There are many trials, but that's the most important one, in which they took thousands of people in a pre-diabetic state, and they divided them into 3 groups. And one group got an intervention called placebo, which is like a fake pill, right? Another group got this medication called metformin, which I told you we use in diabetes. And another group was subjected to lifestyle changes, diet and exercise. And they follow them for a number of years. And at the end of the study period, they measure in each group how many of those who started as pre-diabetic became diabetic at the end of the study period, and use that as a measure of the effectiveness of each intervention. Okay, so the group that had the highest conversion to diabetes was the placebo group. The metformin group did have a 30% reduction of the risk of conversion to diabetes compared to placebo, but the lifestyle change group had a 60% reduction in comparison to placebo to reduce the risk of diabetes. In that group, what they achieved was only a 5 to 10% body weight reduction. That was all. So they needed to lose 5 to 10% to reduce the risk of conversion to diabetes by 60%. Wow. So as an isolated intervention, diet and exercise is the most effective one. All right. Now, what happens if you do both metformin and diet and exercise or lifestyle changes? We don't know, because there wasn't a fourth arm in the study. But it's logic intuitively to think that the combination of both is going to be even better, but we don't really know that. Now, as a physician, going back to the original comment, when you have in front of you somebody with prediabetes, your gut feeling is, let me give this person metformin, because the odds that this person is going to really engage in the necessary lifestyle changes are very low, unfortunately.
Yeah. What a sad, very sad, yeah.
It's a sad story, because they are missing out on the most effective and safest intervention, which, as we know, it's going to lead not only to improvement in the risk for diabetes, but improvement in the risk of many other things.
Wow, that's incredible.
But it's doable.
Yeah, I mean 5 to 10%. So you're going to lose 5 to 10% of your total body weight. So for our viewers, if you weigh 200 pounds, you got to lose 20 pounds. 10 to 20 pounds. Just losing 10 or 20 pounds is going to be more effective than putting you on medication. But what happens is that you go to the doctor and you go home, and when your spouse says, "What did the doctor said? What medication did he give you?" He goes, "No, told me to lose weight." I mean, that the patients don't feel that they got anything if they didn't get a good history from the doctor, a good physical examination, and a prescription on the way out, or a test. Right. Well, the doctor didn't order any test on me. Why? Well, because on examination, he knows what you have. So, yeah, that's a difficulty, but that's a phenomenal study. When you're telling me the study, I thought you were going to tell me metformin, because I'm worried about the compliance of that group that did lifestyle modification. That group must have done very well in modifying their life, because if they're not, it's like the story of The Biggest Loser. Everybody on that show lost weight, but because there was intense therapy. The moment they got off the show, they regained their weight. And it'd be interesting to see what happens to those groups when they stop the lifestyle modification.
Right. Well, there are follow-ups. Now the DPP is a program, actually. Now it started with a trial, but it's now it's a CDC program, and it's ongoing. And there are, in fact, our group is ADA and CDC certified for DPP, Diabetes Prevention Program. So this is an ongoing thing by the CDC. There are benefits. There is a legacy effect too. That was shown also in the DCCT trial for type 1 diabetes and so on. The early intervention in the glucose control seems to have a legacy effect even when you stop doing the things that you did to control yourself, in terms of reduction in cardiovascular mortality and so on.
Good.
So it's a good
deal. I think the takeaway message is we're trying to reduce all the consequences of diabetes, that heart attack and that stroke and all those consequences. So obviously, the pre-diabetic is the biggest group, and those are the group that we can make the biggest impact. So do those thousands of pre-diabetics who are listening to us today and who will listen to us over the next few days and weeks, should they all go see an endocrinologist? Does every pre-diabetic need to see an endocrinologist? And who needs to see an endocrinologist?
It's funny because the answer is no. This is a primary care issue, actually. You need to see your doctor on an annual basis, get tested, even when you're a healthy person. That's when you need to go in. And the conversation of prediabetes management is at the primary care level. In fact, the conversation of incipient, well-controlled, stable diabetes is also at the primary care levels. I think it's never wrong to see an endocrinologist, but you don't really need an endocrinologist unless you are really out of control and that sort of thing. That's not to say that it's wrong to see an endocrinologist if you're a pre-diabetic and so on, but your primary care doctor can deal with it. And also remember the numbers we were talking about before and what the trend is. there aren't that many endocrinologists to really take care of all these people. The diabetes will have, I'm talking about in population studies and in public health, it's what I'm talking about. Primary doctors do have to take care of diabetes because there aren't enough endocrinologists to achieve that. And so when you are in a system like BHMG and so on, you try to channel that and try to stream that line in order to be able to have more access to the people who are worse and so on. But again, there is a middle ground also in that situation.
Yeah, because we have, 2 endocrinologists at Baptist, and we have 200 or a lot of primary doctors, and so they're the ones that are going to help. So the majority of people can see their primary physician. All right, well, that's good. And in regard to a multidisciplinary approach, obviously we've learned that you're gonna take care of them by maybe giving them metformin or insulin, but do they have to see other types of professionals to help them have success long term?
And that's very important because there is evidence that when you approach diabetes in this multidisciplinary strategy approach, the outcomes are much better. Cost of medical care is reduced. We call this the DSME, which are diabetes education programs. And then the multidisciplinary approach involves dietitians, diabetes educators, behavioral, mental health professionals, and sometimes exercise physiologists and so on and so forth. Obviously, podiatry, primary care, endocrinology, all of that is involved in the system. Now, how every diabetic will benefit from this, and there is an ADA certification for this kind of program. Okay, but how intense this has to be depends on how far in advance you are in your diabetes, right? And especially those type 1s, the ones that are on insulin, are insulin dependent, and so on, they do need that kind of a multidisciplinary approach. And the outcomes, the efficacy of this approach is much far greater than me. You see me every 3 months, and I'm an island, and there's another island over there that is a nutritionist, and you don't talk to that person, and there's another one over there, and nobody is integrated. That approach doesn't work, right?
Yeah, so you need all team members definitely to have success. All right, so we've gone over diabetes. We understand what diabetes is. We understand the negative consequences of diabetes long term. Can we cure diabetes? Is diabetes a curable condition? Because I don't want to have it. I have it, and you gave me the diagnosis, and I imagine a patient says, "Doc, I want to be done with this. How do I get rid of diabetes?"
Right. So that question is hard to answer in the sense that I think I prefer to use the term of remission of diabetes rather than cure of diabetes, because I don't think we can say diabetes can be cured yet. Okay, certainly type 1 can't for the moment. Type 2 also, once you become diabetic, the promise that you can cure diabetes, and again, it's a discussion that we can have, but it's hard for me, in my mind, to argue that you can cure it. But you can argue that you can achieve remission. Now, the difference is that when you achieve remission of this condition, you will be off medication and so on. But if the situation changes, you're going to go back and get it again, right? So when you cure something,
the patient wants to be off medication, doesn't want to take insulin, doesn't want to take metformin. How can I be off of medication?
Right. So intense lifestyle changes is something when applied, but that when applied correctly is something that I've seen that people go all the way from being on a just to put you an extreme, an insulin pump using a highly concentrated type of insulin called U500 to being off of insulin on medications only, right? By the same token, somebody who started out with a significant high A1C, and then they started out on insulin, then they move on to drugs, and then eventually came off drugs. I've seen that, but that's so isolated in terms of how many people can actually do that. The other situations in which you can see that is when people undergo bariatric surgery. And that's the other situation that has proven to be highly effective in achieving that type of remission that we were talking about.
Yeah, I've seen three types of patients in my practice that I've seen. Well, I say remission. I've seen, of course, I see a lot of bariatric surgery. So, I've seen diabetics and we operate on them and their diabetes goes in remission. It goes away. They get off medication. But what happens is, as you know, bariatric surgery is not the final solution. And if they regain weight, their diabetes comes back. Obviously, the islet cell transplants, I've seen those where they take the islet cells, the pancreas, and they infuse it in the liver. And then rarely I will see a patient that I'm seeing for another problem. And I say, any medical problem? She goes, well, I used to be diabetic and I'm no longer diabetic for 5 years. And I'm waiting, next point, I'm waiting. She had bariatric surgery. No, I lost 100 pounds on my own. Yes. And that's the strict lifestyle modification. So that's what I've seen, what I call the cure and what our viewers would call cure, that remission occurs. Is islet cell transplant still something done? Is it successful?
So that's for type 1 diabetics, especially, right? And it's something that it's evolving. It hasn't been the panacea, not yet. It was thought that
it was thought so, because I remember it from the 90s. Yeah.
Correct. But it hasn't panned out yet. They are trying to sort of, because as you know, the body rejects some of these islet cells that are seated in the liver. They have tried to seat it in other areas in the abdomen. They have tried to coat those islet cells with certain things to try to avoid the immune attack and so on, but it hasn't really gone that far to say it's a standard of care strategy to be able to cure diabetes. It continues to be done on a research basis in certain places and so on, but at least to my knowledge, I don't think it's yet standard of care as a widespread way to really cure type 1 diabetes. And it's not used for type 2 diabetes.
All right. Well, we've learned definitely that there is a lot of work to be done still with diabetes, and that's why November is Diabetes Awareness Month, and that's why there's so much ongoing research. But what I've taken away from the show is that the majority of people are going to be pre-diabetic. You may not even know that you're pre-diabetic if you don't go to your doctor and get a checkup. And the best way to cure diabetes is lifestyle modification, not medication. So we don't need another pill. We just need less food and more exercise and more activity. So I want to thank Dr. Pascual Pascual De Santis for being here with us today. And of course, not everybody needs to go see an endocrinologist. See your primary physician and tune in with us again for our community health news here at Miami Community Newspapers. Thank you again for having us, and thank you for being with us today.
Thank you for having me. Thank you for the invitation. I enjoyed it.
All righty. Thank you.